Yes, so starting with Unacademy, now plus subscriptions include access to both the live and the recorded sessions, learning from the India's topmost educator, and competing in the live T&Es, and studying on the device of your choice, assessing 25,000 of MCQs, printed and digital notes. Unacademy and Icon subscriptions, Prep Leader and Unacademy has come together. We will get access to clinical integrated essentials, video lecture, QBanks, rapid revision, snapshot, and 2022 dream notes. With well-structured live batches, recorded classes, QBanks, competitive T&Ds, and the digital notes. Under plus category, for 2 years, it is 36,000 rupees. That is costing us around 1,500 per month, and for 2 years it is 2438, that is 58,500 for 2 years. And please do use my code, that is content, to get for the 10% of the discount. Now, updated and highly effective Q banks with 25,000 MCQs based on latest examination pattern and detailed explanations. Special class features include interactive live classes. We can do the polling for the learners, raise a hand, talk to educator, and never miss a class because we'll get notification for the same, and download the lecture notes and get access to recorded sessions of live classes and from anytime and anywhere. Target 2022 batches includes a well-structured batches, modules, GTs, clinical classes, PDF notes, and the practice questions. With 24-month subscription, 4 month is totally free. With 12-month subscription, 2 months is totally free, and with 6 month, 1 is free. With well-structured batches, FMG, GTs, live interactive sessions, and practice Q banks. Okay, so we will now start with the Plasmodium. Starting with the life cycle, now we talk the definitive host for the Plasmodium is the female Anopheles. Female Anopheles mosquito, which is a definitive host and where the sexual cycle is completed. Intermediate host is the man. And what is the infective form? Infective form are the sporozoid forms that are present in the salivary glands of the mosquito. Although the infective form is the sporozoid, but what is the infective form when it is transmitted by the blood transfusion or by the vertical mode? In that case, the infective form will be merozoite. Right? So, sporozoites are the infective form, but when it is transmitted by the blood transfusion, the vertical mode, then it is what? Merozoites. Now, when transmitted by vertical transfusion or the blood transfusion, the difference in the life cycle is that one is that there is no liver stage and the hypnozoites are not produced. Since the hypnozoites are not produced, there is no relapse and there is therefore no need of premaquine. To infect mosquitoes, the gametocyte should be mature and it should be more than count should be well per millimeter cube of the blood. What are the important points from here? That the definitive host for the plasmodium is the female Anopheles, and intermediate host is the man with infective form, that is the sporozoites. But when it is transmitted by the blood a transfusion or by the vertical mode, and the merozoites. When transmitted by the vertical mode or the blood transfusion, there is no liver stage and the hypnozoites are produced, and therefore there is no relapse. Therefore, no need of the premaquine. Now, coming to the life cycle. Now, coming to the life cycle, after the mosquito bite, the sporozoites are discharged where in the blood, and from the blood they are carried to the liver, and in the liver they will exist the liver in the liver cycle, that is the pre-erythrocytic cycle or exoerythrocytic cycle, and the sporozoites will transform to that of the trophozoites, where they will now transform to the pre-erythrocytic schizon, undergoing the schizogony to produce the erythrocytic merozoites. What is the life cycle? Sporozoites will convert to that of the liver, and in the liver they will execute the primary exoerythrocytic schizogony, and they will convert to that of the merozoites, and the merozoites in the blood in the RBC will undergo the erythrocytic schizogony, and you remember that is the MTSM, that is merozoite trophozoite, to that of the Tyson to again the merozoite. Now, depending upon the trophozoite early or late, early trophozoite will convert into the male macro or the micro gametocyte, and the late trophozoite will convert into the schizon, converting to that of the merozoites, and merozoites again going back to the RBCs, executing the same cycle. So, merozoites infect the RBCs, transform to the early trophozoite, late trophozoite, schizon, and undergoes the schizogony to produce the merozoites. Now, release of the merozoites leads to the appearance. It is the release of the merozoites that is responsible to the appearance of the clinical manifestations of the malaria. So, remember, MTSM is easy to remember that from the liver, the merozoites into the blood will convert the trophozoite early and late, and early trophozoite will convert to the macro and the micro gametocyte, and the late trophozoite will convert into the schizon, converting to the merozoite, and this is how the cycle is continuing. Merozoites either attack the RBCs to repeat the cycle or transform to gametocyte, which infect the mosquito. Now, sexual cycle begins when the gametocyte that infects the female. I'm so sorry, I'm a little sick today. I'm not in my well form. So, sexual cycle begins when the gametocytes infects the female Anopheles mosquito and then transform to gamete, then zygote, then ookinete, oocyst, and the sporozoite. And this sporozoite will again bite the human and will infect the person. So that is the infective form for the humans. Now, talking about the recurrence, now it is seen in the falciparum and the malaria. Alright, now falciparum recurrence is due to the persistence of the drug resistant parasite, and the fever reappears after 2 to 3 weeks of the completion of the treatment. And in the malaria, it is the long-term recurrence are seen for long as for 60 years. This is due to the long-term survival of the erythrocytic stage at low detectable levels in the blood. So, what is the reason for the recurrent disease? In the falciparum, it is due to the persistence of the drug-resistant malaria, and it appears after 2 to 3 weeks of the completion of the treatment. And Plasmodium malaria infections, long-term recurrence is due to the long-term survival of the erythrocytic stage. Now, relapse. Now, relapse is due to what? Relapse is due to hypnozoites, which will reactivate after even 3 years of the malaria, seen where in the P. vivax and ovale. And what is the treatment? We give the primaquine for the relapse stage. And relapse is seen in the vivax and the ovale, and primaquine is given for the relapse stage. Now, pathogenesis of the falciparum, sequestration holding back of the parasite in the blood vessels of the visceral organs like the brain, kidney leads toward the vascular occlusion. So sequestration is due to the parasites in the blood vessels, and they will block these blood vessels leading to the occlusion. Cytoadherence, that is the binding of the RBCs to that of the endothelium, rosetting, that is the unparasitized RBCs clumped together with that of the parasitized RBCs, releasing the cytokines and antigenic diversity of the P. falciparum malaria. So pathogenesis is mainly due to the vascular occlusion, and it is the rosette formation of those that are infected RBCs with that of the non-parasitized RBCs. And cytoadherence, that is the binding of the RBCs to the endothelium and releasing the cytokines. Now, immunity, nature of the hemoglobin. The immunity, we know that in the sickle cell anemia, that is protective. We have the three cases that are protective. One is the sickle cell anemia, and it is due to sickling of the RBCs that doesn't provide the proper surface area for the parasite to infect the RBCs. That is the sickle cell anemia. One is the thalassemia trait, and another is what the fetal hemoglobin. Or they all are what protective from the Plasmodium falciparum. Now, we'll talk to the first to the exoerythrocytic cycle, primary exoerythrocytic cycle, where what we were having the merozoites form, the liver, and what is the duration? It is for the Plasmodium falciparum, ovale, and the malaria. The duration is 6, 8, 9, and 13. It is 6, 89, and 13 for the Plasmodium falciparum, vivax, ovale, and for the malaria. Now, coming to the next cycle, that was the erythrocytic cycle. That is the erythrocytic cycle, and we have the Plasmodium falciparum, then we have the vivax, ovale, and the malaria, and the falciparum will invade all the age of the RBCs, and vivax will involve the young RBCs that are less than 14 days old, and the ovale will infect the reticulocytes, and viv and malaria will infect what the old RBCs. So that is the first we talked about the exoerythrocytic cycle, where we have the merozoite form, and we have 6, 8, 9, and 13 days of duration for the falciparum, vivax, ovale, and the malaria. And in case of the erythrocytic cycle, falciparum involves all the ages of the RBC. Then we have the vivax, ovale, and the malaria. Vivax and the ovale, they mainly involve the young RBCs, and the vivax involves the RBCs that are less than 14 days old, and the malaria that is involving the old RBCs. Then we saw about the gametogony, micro and the macro gametocytes, that is seen only in the capillaries of visceral organs. Alright, we see that in the capillaries of the visceral organs, and then we talked about the sporogony, where it infects what the mosquitoes, and it is around 10 to 14 days duration. Then we have the secondary exoerythrocytic cycle, that was the relapse or the reactivation of the hypnozoites, and which is only seen in the vivax and the ovale, not in the falciparum or the malariform. Going to the next one. Nature of the enzymes. G6PD deficiency is also protective. We talked about the fetal hemoglobin, sickle cell anemia, and the thalassemia trait. They all are protective from the Plasmodium falciparum. Then we have the G6PD deficiency, that is also protective from the Plasmodium falciparum. Ovelocytosis, RBC is rigid, so protected from the Plasmodium falciparum. Duffy negative RBCs, that is also protected from the Plasmodium vivax. Nutritional status has a paradoxical effect, and the HLA, BW53, and haplotypes bearing DR213 antigen and the R11 gene, they are also protective. So we have the fetal hemoglobin, sickle cell anemia, thalassemia, G6P deficiency, ovelocytes, Duffy negative RBCs. The malnourished people, they has a paradoxical effect, and they are more protective with that of the malaria. Then what are the disposing factors? Predisposing factors for that of the malaria, that is the density of the vector. More the density, more the load, more is the clinical symptoms, and that is the predisposing factor. Number of the human bites per day per mosquitoes, and what is the time of the mosquito bite, that is more after the dusk. Optimum temperature, that is 20 to 30 degrees Celsius. Optimum humidity, that is up to 60 percentage. Rainfall and altitude below 2000 meters, and the longevity of the mosquito, as the sporogeny we talked about, that lasts for 10 to 14 days. Thus to transmit, the mosquito must live more than 7 days. Now, talking about the situation in the world, the most affected are the sub-Saharan Africa, followed by the SEAR regions, and in amongst all, Vivex is the predominant, and the age that is mainly affected in the malaria are the children. So, children are mainly affected, and the Vivex is the main plasmodium that is infecting. Now, moving to the next, when is the World Malaria Day celebrated? It is on the 25th of the April, right? We have mainly Plasmodium falciparum, and in the Odisha that is affected as the most, where 92% cases are due to the Plasmodium falciparum, and we mark 25th April as the World Malaria Day. What are the clinical features of the malaria? Now, when we talk about the clinical features of the malaria, now first is the febrile paroxysm. That is this is released along with the synchronous release of the merosomes from the RBCs. All right, and what is the incubation period? What is the incubation period for the Plasmodium falciparum, Vivex, and the ovale, and for the malaria? For the falciparum, it is the shortest, that is the 12 days, followed by the 13 to 16 days, and for the malaria, it is longest, that is 28 to 30 days. So that is the, yeah, hi, hello. Good morning. So, what is the incubation period? Falciparum is the most aggressive one. So, incubation period will be shortest, that is 12 days. Then we have 13 to 16 days for the Vivix and the ovale, and for the malaria, it is 28 to 30 days. Now, fever, sweating, anemia, hepatosplenomegaly, irritability, coma, retinal hemorrhage, and it is all due to the vascular occlusion. Then we have algid malaria, which is a shock-like syndrome, and the respiratory distress syndrome. What are the complications? Complications are the cerebral malaria. Then we have the black water fever, splenomegaly syndrome, malaria hyperpyrexia, GIT disorders, algid malaria, nephrotic syndrome, and the promotes aggravates the Burkitt's lymphoma. Now, talking about the laboratory diagnosis. So, talking about the laboratory diagnosis. Now, first is the gold standard. Now, what is the gold standard method for the malaria? It is the microscopy. All right, what is the gold standard method? It is the microscopy. The reason being that it has the good sensitivity. It has good sensitivity, and it detects around 5 parasites per microliter of the blood, and it is a cheap method. It is a cheap method for the species identification and for the quantification of the parasitemia. Now, examination of the PBF, that is a thin and the thick blood films. Gold standard method, very important, that microscopic tests are the gold standard methods for the malaria. We have the thick smear and the thin smear. The thick smear is used for the identification, and the thin smear is used for the species identification. So thick smear we are using for the malaria pigment, that is mainly for just for the identification of the malaria and which type of the malaria species it is. We use the thin smear. Feathery tail end of the smear should be examined for the species identification. At least 200 to 300 oil immersion fields should be examined before considered to be negative. So that is about the microscopic test. That is a gold standard cheap method, has a good sensitivity, and it is thick, and the thin smear thick is used for the quantification identification of the malaria, and for the species identification we are using what the thin smear. Now, talking about what are the stains that we are using for the microscopic test, what are the stains that we are using for the microscopic test? Yes, what are the tests we are using for the staining? For the microscopic test, we are using the stains. Remember, the name of the stain that we are using are the JSB stain. What is the JSB? It is Jaswant Singh and Bhattacharya stain that is used in mainly in the malaria programs in India. Other than this, we are using, apart from the JSB, we are using the Jamesa stain because we generally use the Jamesa stain in the histopath for the staining of the abaces and the fills and the right stain apart from this Leishman stain. Now, what is Kawamoto technique? Now, it is a fluorescent microscopy that is by the acridine orange dye. We are using the stain that is the Kawamoto stain. Now another is the QBC method. One we are using the JSB stains, other we are using the Kawamoto techniques that is a fluorescent by the acridine orange stain. And we are using the QBC's method that is rapid method test for the parasites, and the blood is collected in the capillary tube that is coated with the acridine orange dye, and with it is centrifuged and the capillary tube we centrifuge and examine the buffy coat, and we at the junction of the RBCs and WBC, we get the parasites that is the malaria, and that is this is the quantitative Buffy coat examination under the Kawamoto technique by the fluorescent microscopy. So stains we are using the JSB, Leishman, and the James right stain. Then we are using the Kawamoto technique by the fluorescent. Under fluorescence, we are using the acrid and orange stain to see at the junction of the WBC and RBCs to check for the parasites under the fluorescence. Now, what are the other methods? Apart from this, we are using the non-microscopic test. That is, first is the antigen detection test, rapid diagnostic test, or the immunochromatographic test. That is ICTs. They are rapid, but the problem is that they are rapid tests, but they are less sensitive tests. Therefore, they may also give the false and the negative cases. And we detect for which antigen, that is one is the lactate dehydrogenase and the aldolase. They all are present in all the Plasmodium species, but then we have the HRP, that is a histidine rich protein 2 antigen, which is only found in the falciparum. So please remember that antigen detection test we are using the RDTs and the ICTs. They are rapid, but they are less sensitive. They are costly. They may give the false and negative test results. And we see for the LDH and the aldolase that are present in all the malarial species. But HRP2 antigen, that is histidine-rich protein, they are found only in cases of the Plasmodium falciparum. And this is also known as the parasite F test, that is the parasite falciparum test, because histidine rich protein 2 is found only in the falciparum, not in other Plasmodium species. Therefore, it is also known as the parasite F test. Now, a next method that we use is the antibody detection test. That is an epidemiological survey in India and the screening of the blood banks to identify the infected donors. We use the antibody detection test. Next is the culture of the malaria parasite, Traeger and Jensen's method we use. We use the Traeger and the Jensen's method, and molecular methods, that is a PCR using the PPRK1 primer. Uncomplicated benign malaria in India. Now, we'll also see the PBF, in which we'll see the Schnaufner's dot or the James dot or Morris dot. That will these slides will read after completing the laboratory diagnosis. Now, uncomplicated benign malaria in India. Now, for the uncomplicated cases, chloroquine is the drug of the choice for the uncomplicated cases. and it is given around 25 mg per kg divided on the 3 days. So remember, for the uncomplicated cases, chloroquine, and for the relapse of the Vivex, we give the primaquine, because in relapse cases for the Vivex or the ovale, we give the primaquine, and therefore we read about when it is transmitted by the vertical transmission or by the uh, this blood transfusion. That was what was the infective form, that was the merozoites, and relapse was not there because no liver stage was involved in that. Therefore primaquine is not given, as primaquine is given for the relapse cases. Now, into the complicated cases or the falciparum malaria in India, treatment of the falciparum malaria in India is based on the area, because certain areas are resistant and certain areas are still sensitive to that of the chloroquine. So first we give is the artemisinin combination therapy is recommended, where we cannot give the chloroquine. On in those areas we give the ACT, where chloroquine cannot be given. Now, artemisinin combination therapy consists of a combination of the artemisinin derivative and long-acting anti-malarial drugs like the sulfadoxine, pyrimethamine, or mefloquine, or lumefantrine. So that is the artemisinin combination therapy. Along with the artemisinin derivative, we give the anti-malaria drug. For the treatment of the falciparum cases, quinine with the combination of the doxy or the tetracycline recommended. So, although the treatment is the chloroquine, in those areas where chloroquine cannot begin, we give the ACTs, like in the northeast part of the India. And for the treatment of the falciparum, we give the QDT, that is the combination of the quinine with that of the doxycycline with or with doxy or tetracycline. Chloroquine resistance area with artemisinin combination therapy is recommended. We have all of that is Odisha, Jharkhand, MP, Chhattisgarh, and Andhra Pradesh. In pregnancy, quinine is recommended at first trimester, where ACT is given at the second trimester. So, at in the first trimester, we give quinine, and second and third trimester we give the ACT. Now, treatment of unconfirmed cases of mixed infection should be treated as the falciparum plus primaquine is given for the radical cure. Since we don't know that it is whether it is a which case of the malaria, so we'll treat as aggressive malaria. We give treatment as a falciparum malaria, that is a QDT, quinine plus doxy plus or tetra. Along with that, the primaquine in case if it is not falciparum, to prevent the relapse cases or the relapse stage of malaria. Now, we'll talk some important points about the PBF, and we'll in detail see the slides about them. Yes. Now, talking about the Plasmodium. Now, first we'll talk about the PBFs. We discovered that we just read that the gold standard method is the microscopy using the Jaswant Singh Bhattacharya method, or using the Jimsa or the Leishman stain, and thick and thin smears, thick for the identification of the malaria, and thin smear for that of the species identification. Now, talking about the Vivex and the ovale. Now, infected RBCs. Now, first is that they infect all the young RBCs. If you remember, they infect all the young RBCs, and the infected RBCs will be enlarged. Okay. Then we have the early trophozoite stage. Then we have the late trophozoite stage. We have the schizont stage and the gametocyte stage, that is the amoeboid form. All right. And what we have the Schoffer's dot and the James dot, which gives the Schaffner's dot in case of the Vivex, and James dot in the ovale, which gives the yellow pigment. Now, talking about next one, that is the falciparum. Now, in these cases, infected RBCs will be of same size, and we have the early trophozoite stage, absent schizont stage, and the early trophozoite stage, that is ecol, or the in the form of the ecol forms, and we have the Morris dot and the ring form in the early trophozoite stage. And gametocyte, that is important, gametocyte, that is crescent or banana shape, that is crescent or banana shaped gametocyte. We'll also see the PBFs. Now, talking about the Plasmodium malaria, here also the infected RBCs will be of same size, and here late trophozoite will be in the form of the band form and will be brown pigmented. Now let's see these what we have discussed. Now talking about the first, that is the Plasmodium falciparum. If you can see, this is the gametocyte and this is the crescent shape or the banana shape. This is the crescent or the banana shape in case of the Plasmodium falciparum. And what else we had? We had the early trophozoite form in the form of the ecol form. So parasite RBCs are not enlarged, that is the same size RBCs. RBCs containing the mature trophozoite sequestered in deep vessels, total parasite biomass, that is this. Now moving next, Vivax. In the Vivax and the ovale, the infected RBCs, you can see the infected RBCs are little larger than the adjacent the Vivax and the ovale, the infected RBCs is larger. And we have parasite prefers young RBCs. In case of the falciparum, they were involving all age groups of the RBCs, while in the Vivax and the ovale, they were preferring what the young RBCs which are less than 14 days old. Alright, and we have all the stage present in the peripheral blood. In both the Vivax and the ovale, we have the early trophozoite, late trophozoite, we have the schizont stage and the gametocyte stage. They all were present, and we were having what? The Schaffner's dot and the James dot. In Schaffner's dot in case of the Vivax, and the James dot in the that ovale. Now, next we are left with the Plasmodium malariae. Here, the infected RBCs is of the same size, and you can see this band form. This is a band form, that is a brown pigment form, that is the present in the late trophozoite form of the Plasmodium malariae. So we have here band form, we here have the banana or crescent form in the gametocyte, and the James dot and the Schaffner's dot and the Morris dot in case of the falciparum. Now, talking about the Plasmodium vivax, that is a significant cause in the relapsing where dormant form in the liver. In fact, we have the, in case of the vivax and the ovale, that is the ring form, that is a trophozoite form. Then we have the amoeboid trophozoite form, Schaffner's dot in the trophozoites. That is a scattered dots you can see. And again, gametocyte is also amoeboid form, eukaryote and the schizon stage. So Plasmodium vivax and the ovale, talking about the Plasmodium ovale, that is having the James dot and the Schaffner's dot in the vivax in the trophozoite form. Now, note the coarse purple scattered granules, that these are the Schaffner's dot, and where do we get in the vivax, and similar to that in the ovale, that is the James Now, this is the Vivex that is having Schaffner's dot. Then we have the ovale in the trophozoite scattered form that is a dark brown James dot. Then we have the Morris, Morris dot cleft or the dots that are found where in the falciparum and in the malaria that is the Z-mens dot. These are the light brown. So this is an important slide. We have the Schaffner's dot, James dot, and the Morris dot as well as Siemens dot that is found in the Malaria and Morris dot in the falciparum. Talking about the Plasmodium falciparum, it is a predominant species in Africa and invades all the RBCs. RBC's destruction is rapidly stick to the wall of the neurovasculature, microvasculature, and you can see the ring stage in the peripheral blood edge position, and they shows the Morer's cleft in the trophozoite form, no RBC distortion, and the gametocyte is what the banana shape or the crescent shape. Alright, and the ring form in the trophozoite form. These are the ring forms. These are the even double ring forms is also seen that is the plasmodium falciparum. Ring stage in the peripheral blood and the Morer's cleft. Now, coming on next one, that is the Babesia. Now, Babesia, they are the intra-erythrocytic protozoa. They are again intra-erythrocytic protozoa, just like the malaria, and they produce the malaria-like illness in the animals and the zoonotic, causing the opportunistic infection to the humans. It is not found in India. Vector is what the tick bomb. Babesia is not found in India, and it is also intra-erythrocytic protozoa, causing the zoonotic disease, illness similar to that of the malaria. Treatment is given what is a clindamycin with oral quinine and the atoquine azithromycin. How does it differ from the malaria? Now, hemozyme is absent. Gametocyte cannot be distinguished from the asexual forms, and Maltese cross very important. Maltese form ring forms are arranged in that of the tetrads. So, this is the Maltese cross. You can see they are arranged about in tetras. The Maltese form, the ring form, in the trapezoids, they are arranged in what? Tetrads, and there is no hemozoin, and gametocytes cannot be distinguished. The sexual and the asexual stages cannot be distinguished in case of the Babesia. Yes. Now we'll just revise in 10 minutes and we'll do the question answers for the same. Yes. So, starting with the life cycle, important point is to remember the definitive host that is a female Anopheles, intermediate host is a man, and the infective form is a sporozoid. In case of the transmitted blood transfusion, vertical mode, it is a merozoids, and there is no liver stage. Since there is no liver stage, no hypnozoids will be formed, and therefore, no need of giving the Primaquine. Now, to come to life cycle, the sporozoids are discharged into the blood, and from there they move that of the liver, converting into the merozoites, where the primary exoerythrocytic chysogony and the merozoites released into the blood. They infect the RBCs and follow the route that is the MTSM. You can remember by this MTSM, merozoites transfers into the trophozoite early and late. Late trophozoite will convert to the schizones again to the merozoites, and the early will convert to the macro and the microgametocytes, which will be through the blood meal will be taken by that of the mosquitoes, and where they will complete their sexual life cycles, and the clinical manifestations are synchronous with that of the release of the merozoites. Now, recurrent tenses, Plasmodium falciparum malaria. Recurrence is due to the persistence of the drug. We have the recurrent disease in the Plasmodium falciparum as well as the malaria. And in the falciparum, it is due to the drug resistant parasites that resides even after the completion of the treatment. And in the malaria, it is due to the long survival of the RBC erythrocytic stage, which are not detected in the blood. Then we have the relapse. We have the relapse in the vivax and the ova. And treatment we give for the relapse is primaquine. Moving next, pathogenesis. Now talking about the pathogenesis, now sequestration that is holding back of the parasite in the blood vessels. Now blood in the parasites, they block actually the blood vessels. Apart from this, there is also cytoadherence of the RBCs. That is, the RBCs are attached to that of the endothelium of the blood vessels, and there is rosetting. What is rosetting? The unparasitized RBCs clump together with the parasitized one. Also, this is how the vascular occlusion takes place, and the clinical manifestations of the malaria takes place. Now, nature, now what are the protective natural hemoglobins for sickle cell anemia, thalassemia, and the fetal hemoglobinemia? And apart from this, G6P deficiency, ovelocytes, Duffy negative RBCs, and even malnourished. Now, talking about the primary exoerythrocytic cycle, what is the duration? It is 6, 8, 9, and 13 for the falciparum, vivax, ovale, and the malaria. Then we have the erythrocytic cycle. Now, malaria, we have the falciparum, which infects all the RBCs. Vivax and ovale will involve the young RBCs, and the malaria, this will involve the old or the sensicant RBCs. Then we have the gametogeny, which takes place in the capillaries, and the sporogony, which takes place in the mosquito, which is around 10 to 14 days. These are the predisposing factors depending on density of the vector, number of the human bites, times of the human bites, and the mosquito bites. What is the humidity, temperature, and the altitude? Now, epidemiology, we have the Vivax is a predominant and the age is the children mainly affected, and the malaria day, that is the 25th of the April, and the Odisha is mainly affected state. Clinical features, the fever and the sweating, that is a febrile paroxysm, which is synchronous with the release of the meiocytes from the RBCs. And what is the incubation period? That is 12 day, 13 to 16 day, 28 to 30 days. 12 days for the Plasmodium falciparum. For the vivax and the ovale, it is 13 to 16 days, and 28 to 30 days for that of the malaria. Diagnosis, how do we do? It is the gold standard. These are the complications: cerebral malaria, blackwater fever, GIT disorders, algid malaria. Then we do the microscopic test, which is a gold standard. We use the JMB method, that is the JSB method is Jaswant Singh Bhattacharya, Leishman, James stains for the thick and the thin smear preparation, and the thick is used for the identification of the malaria, thin is for the species identification. It is a chief method, it is a gold standard method with high sensitivity, and we can detect 5 parasites per microliter of the blood. Next is the Kawamoto method, which is a fluorescent based method. We use the alkylene orange dye, and we prepare the QBCs by centrifugation, and at the junction of the RBCs and the WBC, we check for the parasites under the fluorescent fluorescence. Then we have the RDTs and ICTs, in which we check for the antigens, that is the LDH and the aldolase, and the HRP2 antigen, that is the histidine rich protein antigen detection, that is specific for that of the Plasmodium falciparum, and it is also known as the parasite F test for that of the Plasmodium falciparum. Then we have antibody detection test, which is mainly for the infected tumors, and the molecular methods. For the uncomplicated cases, we are giving the chloroquine, and for the relapse cases, we are giving the primaquine. Then we have the complicated cases, we are giving the chloroquine. If chloroquine resistance is there, we are giving the ACTs, and for the treatment failure of the falciparum cases, we are giving the QDT, that is a quinine plus doxycycline plus tetracycline, that is recommended. Now, chloroquine resistant cases, we are giving the ACT. In pregnancy, quinine is given in the first trimester, then we give the ACT from the second and the third trimester. Now, we've already seen that in the falciparum, all the ages of the RBCs are involved, and RBCs, they are what they are. For the malaria, for the falciparum, they are of the same size, and we can see the ring form, and double ring form is also seen in case of the this falciparum. Then we have the vivax and the ovale, where the RBCs are enlarged and we get the Schaffner's dot and the James dot in the merozoite form. Then with the Plasmodium malaria, we get the band form in the tropozoite form, and the banana and the crescent form in the gametocyte form of the falciparum, and the ring form in that of the merozoite form of the Plasmodium falciparum. Now, moving next, these we've already discussed. Then we talk about the Babesia, which is also an intra-erythrocytic protozoa, and it also produces the malaria-like illness. Although it is not found in India, it is a tickworm and tick-borne, and treatment is clindamycin. But there is no, we cannot differentiate the sexual and asexual forms. And the Maltese cross, the tropozoite form, they shows the Maltese cross that are seen in the tetrads form, and hemozoin is absent. So this is the Maltese cross that is for the Babesia, and very important PVF, that is you can see the tetrad form of the tropozoite form of the Babesia.